Okay, so hello, I am Allison Cowan. I am a psychiatrist for Ohio's Telepsychiatry Project for Intellectual Disability. Okay, so I will need you all to, if you haven't been to one of these with me before, we use the chat function a lot. I think it might be called like questions. So if you could go ahead and just type into that, like, I don't know, hello, or maybe, I don't know, any random fact about yourself would be great. Okay, so thank you, all of you who did just that. So what we're gonna do is we're gonna do a lot of interaction. And so we are gonna use the chat function for that. Oh, yes, hello from Jefferson County, good to see you. So we'll do that. So I will ask you a lot of questions. What I'm going to do is walk you, you know what? I bet I have a slide for this. Let me just click to that slide. I'm getting all out of order here. Okay, so my disclosures is that I don't have any disclosures. I don't have any conflicts of interest, industry or pharmaceutical sponsorship. I do have grant support from the Ohio Department of Mental Health and Addiction Services. Thank you very much. From the Ohio Department of Developmental Disabilities. Also, thank you very much. And Ohio's Telepsychiatry Project for Intellectual Disabilities. We're not going to talk about any cases today, but if I do bring any up, they are de-identified composites and they do not describe any one single person, just so that you don't have to worry about that. Oh, look at you all. Yes, hello from Licking County, and then from Henry County. Love it, love to see it. All right. So we will do that, and then, let me tell you a little bit more about my project. So it's not mine, it's our project, Ohio's Telepsychiatry Project for Intellectual Disability. It started way back in 2012, so we were doing telepsychiatry for 10 years now. We serve 86 of Ohio's 88 counties. We have over 2,400 patients, and we train medical students interested in IDD psychiatry, and we train psychiatry residents to be psychiatrists who feel secure in treating people with IDD, because that's something I hear a lot, is like from psychiatrists. Even psychiatrists will say like, I don't know if I feel comfortable treating somebody with like these disorders or these co-occurring conditions. So we work really hard to train psychiatrists to be competent clinicians and excellent clinicians. Okay, so at the end of this course, you will be able to describe the scientific literature base for the diagnosis of IDD and personality disorders. The spoiler there is that there just isn't very much. And we are going to collaboratively work together to list the adaptations for the diagnosis of personality disorder in somebody with IDD. So what we'll do is I will give you the DSM-5 TR, like a boiled down version of the DSM-5 TR criteria for personality disorder diagnosis. And then we're gonna brainstorm together what limitations those descriptions might have in making that diagnosis in somebody with IDD. And then we'll go over what the DMID-2 suggests. So the DMID-2 is the NAD produces so it's the National Alliance for the Duly Diagnosed, so people who have mental illness and intellectual and developmental disabilities. So it looks at psychiatric diagnoses in the setting of somebody with IDD, and it's their diagnostic manual that takes the DSM-5 TR. Sorry, it's actually just DSM-5 criteria and then adapts them for people with IDD. So hopefully that helps, like to lay out what we'll be doing. And then we will have some discussion of treatment options as well as practical suggestions for clinicians. And a lot of that, I'll try to be very clear about what is my own personal gained wisdom or knowledge and what is based in the literature, and then where the gaps are. So I hope this is helpful. I find personality disorders to be the most interesting of psychiatric disorders, very often the most like contentious, and one of the most stigmatized group of illnesses that we have. So we'll also talk about that at length too. So I hope you're ready. Oh, can I zoom in on the shared slides? I don't know. Is it big enough for everybody else? Can everybody else see the slides okay? That might, okay, everybody else says yes. So I don't know, maybe just use the Zoom button. Sorry for not helping. Okay, let's see. So what is a personality disorder? So from the American Psychiatric Association's website, which is psychiatry.org, these are long-term patterns of behavior and inner experiences that differ significantly from what is expected. So these are the ways a person goes through life that are kind of separate from societal norms. So the pattern begins by late adolescence or early adulthood and causes distress or problems in functioning. And so the personality disorders can be described as a way of thinking about yourself and others. It can be a pattern of how a person with personality disorder responds emotionally. It can be how you relate to other people. And it can be a way of controlling controlling or not controlling one's own behavior. So let's see. So that it's kind of talking about like a very broad description. Now there was some controversy, gosh, I think when DSM-5 came out about that there just isn't a lot of scientific literature about personality disorders as a whole in like in the population as a whole. So that means that certain disorders were actually suggested to be dropped from DSM-5, but there's such like an outroar or an uproar about it that the DSM-5 committee elected to keep them in. So that's just the kind of historical background there. But a lot of these were described, you know, like 50, 70, 80 years ago, and they've just kind of like have stuck around with not a lot of scientific basis in their diagnosis. Very interesting subcategory of psychiatry if you're into that kind of thing. All right. So the prevalence in the United States. So this is one of your CME questions that the answer A is 7% and answer B is 12%. And I asked Megan if we could have both A and B be correct, because it's about 10%. And there's a range depending on which study you look at. And then the range for people with IDD it's wild. There's just not a lot of good evidence. So sometimes, like, some studies will say 1%, and then some studies will say 91% of their sample size had a personality disorder. Yes, LOL. It's just we really need more information. We just don't have enough. We don't have enough research to make good conjectures about the prevalence, like how many people who have IDD have a personality disorder. All right, so let's start. So there's broadly 3 categories of personality disorders. There's odd or eccentric, there is dramatic, emotional, or erratic, and then there's anxious or fearful personality disorders. So let's take a look at the first cat. It's called cluster A. So if you ever hear somebody described as cluster B, that will be the next category that we'll talk about. We will spend significantly more time talking about borderline personality disorder and antisocial personality disorder, but I want you to have a good like working knowledge of these other personality disorders that still happen, but we just don't clinically see them as much. So paranoid personality disorder is a pattern of mistrust and suspiciousness such that others' motives are interpreted as malevolent. So that's just like what you would expect. Somebody is paranoid, they kind of just live their life like that. They suspect people who are just kind of friendly, like who bring cookies over when you move in, like they figure that they're like up to something. And it doesn't rise to the level of a paranoid delusion like schizophrenia. There aren't other symptoms. They just view everyone kind of suspiciously. And yes, for those trauma-informed caregivers out there, there also is a background there of some more likely childhood trauma is more likely in a person with paranoid personality disorder. So schizoid or schizoid, depending on how you say it, I say schizoid. Also just a really interesting personality disorder. There's this detachment from social relationships and a restricted range of emotional expression. So these people with schizoid personality disorder are just really not interested in other people, not really interested in like a social relationship or those connections, and have kind of limited expression of emotion. Schizotypal personality disorder, or schizotypal, also one of those ones that people say both ways. If you tuned in last week or the week before, we talked about this one. So schizotypal personality disorder is now categorized in the psychotic disorders section of the DSM, but it's also described here as a personality disorder. So it kind of inhabits both areas. So there's some acute discomfort in close relationships, some cognitive or perceptual distortion, so they kind of experience the world in an unusual way, and then eccentricities of behavior. Also, this is like one of the pictures that pops up if you search eccentric, and I thought that was a great example. All right, so dramatic. So this is cluster B. So when you see on somebody's chart, it says cluster B traits. It's talking about this kind of these personality groups. So antisocial personality disorder is a disregard for the rights of others, criminality, impulsivity, and then failure to learn from experience. Borderline personality disorder is an instability in interpersonal relationships, self-image, and affects, meaning like expressed emotion, as well as impulsivity. Histrionic personality disorder, and we're going to talk about those like in depth. Histrionic personality disorder is excessive emotionality and attention seeking. Histrionic was one of the ones that was suggested to be dropped from DSM-5, but it stuck around. And then narcissistic personality disorder, another one I think that was suggested to be dropped. And I think it was 2013, but has stuck around. So grandiosity, need for admiration, and a lack of empathy. And then this is the cluster C group, so anxious or fearful personality disorder. So avoidant is a pattern of social inhibition, feelings of inadequacy, and hypersensitive to negative evaluation. Dependent personality is a pattern of submissive and clinging behavior related to an excessive need to be taken care of. And then obsessive compulsive personality disorder is a preoccupation with orderliness, perfectionism, and control. Okay, oh, somebody's asked in the chat, which personality disorder most closely encompasses ADHD symptomology? I would say ADHD, which is not a personality disorder diagnosis, and I'm sorry that does not answer your questions, or answer your question, but like that ADHD is a psychiatric disorder like of its own. Any kind of personality symptoms that go along with that would be personality symptoms rather than the ADHD like diagnosis. So that was, I'm sure, very like a very unhelpful answer. But yeah, that's just how it is. Like there's ADHD, it's like depression or anxiety, and then so they're kind of separate. There are overlaps there, which can make treatment interesting or challenging in some cases. All right, so what does the scientific literature look like for people with personality disorder and intellectual disability? I don't know if you can see this, you probably cannot. When I Google Scholar searched personality disorder, intellectual disability, I get one result, like one result, and it was in 2003. So it's like there's just isn't a lot of research about this. A lot of what we do is taking the personality disorder research for the population as a whole and kind of extrapolating, or I guess interpolating for people with IDD. But very often, as we've discussed before, the research, it's very common to have an exclusion criteria that excludes people who have an intellectual disability diagnosis from research studies. So it's just like we don't know, they aren't included in studies. So we just have a lot of missing data. So if anybody needs a research study, this sounds like great. I would be so proud. Okay. And then if you look up, I did use an old term, like our old term for intellectual disability. So there is a lot of data out there, but it's mostly old. So a lot of the stuff that comes up is from the 90s. One of these citations is from 1936. If that kind of tells you about like the state of the art, that a lot of the research is like from what, 30 years ago. I'm sorry to break that news to anybody out there, but the 90s were 30 years ago is also really hard for me to take. Okay, so we do have case studies. A lot of the research done in people who have personality disorders and intellectual and developmental disability are in institutional settings, and sometimes that is also correctional settings. So there's a reasonable amount of research in sex offending people who are incarcerated who also have a diagnosis of IDD. So there's some evidence about that, but then we're just missing a lot of information. And there is some discussion of the overlap of co-occurring medical conditions, so like seizure disorder and brain injury. How does that impact? Because seizure disorder and brain injury can also impact your kind of interpersonal functioning. They can impact how impulsive or hot-tempered you are. So all of those things that are both a brain injury symptom and a symptom of a personality disorder can be complicating. Ooh, okay. Somebody says, can you have more than one personality disorder? Yes, you absolutely can. And then, are there any personality disorders that you see more consistently or commonly with autistic individuals? That's really interesting too. When we get down to OCPD, I will tell you about my very own personal idea that there are a lot of people previously diagnosed with OCPD, obsessive compulsive personality disorder, that might have actually might have met criteria for autism spectrum disorder, or what we used to call pervasive developmental disorder, not otherwise specified, or Asperger's syndrome. But that's my own personal ideas, and I don't know that that's the point of this talk, is for me to for me to tell you, like, this is my idea, let me tell you about it. But maybe it is, and we can get there. Okay. Okay, so this is how we'll be discussing it today. So I'm going to give you some of the DSM-5-TR categories. I'm going to ask you to think about what limitations how using those criteria could be limited in somebody who has mild intellectual disability. They might have moderate, severe, or profound intellectual disability. So I'm going to ask you to participate that way, and I think that would be very good. I'll try to keep an eye on the chat here. Oh, and we have somebody else agrees with my idea about that overlap of obsessive compulsive personality disorder and some of the autism spectrum symptoms. Good, I'm glad. I'm glad there are more of us out here. Okay. So I want us to remember as a whole that the culture of disability talked about in the DMID2 is, as a culture, it's a really interesting way to think about it, and it can be very helpful. So things that are culturally appropriate, if you have an intellectual disability and you attend a sheltered workshop, like those things are important to keep in mind. And then the DCLD is Great Britain's version of the DMID2. So they took their diagnostic criteria and adapted them. So they call intellectual disability learning disability, which is confusing in the literature. So this is the diagnostic criteria for people with learning disabilities, aka intellectual disabilities. So they suggest not making a personality disorder diagnosis in somebody with severe or profound ID. So people with severe and profound ID typically have very limited communication. Expressive and receptive communication is usually pretty impacted. So it's difficult to make these diagnoses, which usually have like some serious nuance in like ideas, like kind of abstract concepts that somebody, we might not be able to assess those things in somebody with severe or profound ID. Now, I want you to keep in mind if a person's current environment, how that's impacting how somebody acts. I don't know if you've ever been in like a terrible job or like a terrible relationship or like a terrible situation where you kind of act outside of how you normally do. You might be really angry or really snappish. So those situations, I think, are really important to remember for the folks who have IDD, because so much is not up to them, like where they live, who their roommates are, like what's for dinner, if you can stop by McDonald's on the way home if you had a really bad day, all those kinds of things. A lot of the patients that I treat don't have access to what I would call those kinds of coping skills. I'm not suggesting anybody treat their bad day with fast food, but sometimes I think we've all been there. And then the limitations on intimate relationships. Very often somebody will have a guardian, or they just won't have the ability to get together with their boyfriend, girlfriend, partner in a way. If you've ever worked with somebody who had one service provider agency and then their partner, spouse, girlfriend, boyfriend, whoever had another, like how hard it is to like get them together to go out to like Applebee's on a date night. It's like pretty complicated, and it takes a lot of additional work and communication between those two agencies. So just the limitations on that can be really, really difficult. Sometimes people aren't allowed to date either, even like as adults, their guardians or their family does not allow that. Okay. Also, the other notes that the DMID2 talks about is dependency. So people who live in congregate settings, people who need like additional supports from a service provider agency, or have like a home manager, or have occupational physical therapy. There is increased dependency just kind of built in, like people need more supports. So just keep that in mind. We'll talk about this a little bit down the road, but also just fear of failure. The DMID2 talks about just the repeated experience of failure can just really be demoralizing and make you not want to take new risks to try something again. So it can make you more reliant on others. And then if somebody is allowed to have decision-making practice, so does the person you're working with have a budget? Are they allowed to like work through, like if I spend all of my money on Funyuns this month, how will I then have, I don't know, spaghetti for dinner like 2 weeks from now? Like those kinds of things. If somebody is not allowed to have practice at making decisions, you might not be very good at it yet. And then let's remember expressive and receptive language skills. That does, I guess, color how we make diagnoses, and I guess it informs how we make those diagnoses. Yes, somebody has pointed out it is a rights restriction, so legally as an adult they can date. Yes, thank you for pointing that out. I agree. Yes, that's true. The agency just needs to advocate for the guardian to realize that they can't stop it. Then thanks for coming to my TED Talk. Yes, agreed. Yes, so people should be allowed to date, have sex, have those intimate relationships. Practically speaking, sometimes it is forbidden. But yeah, I do agree that it is our job to advocate for those important connections. Absolutely. Okay. And then my last note is anger. Anger is a commonly observed phenomenon in people who have intellectual and developmental disabilities. Think about the last time you were very frustrated, stymied, were stuck, you felt boxed in, you felt like you didn't have any choice. Anger was probably in your complex range of emotions that were swirling around inside you. And sometimes if you have a lack of expressive language, it might all bubble over into anger. So that's just an important note to make. Several of the personality disorder diagnoses include anger as one of the diagnostic criteria. So it's just important for us to kind of look at the situation and say, well, is that reasonable? And very often it is. It's like, well, so-and-so always gets to sit in the front seat. I get car sick and I have to sit in the back every single time. Yeah, I would be mad about that too. Okay, so let's start. Paranoid personality disorder. Okay, so we kind of talked about this, but suspects others without sufficient basis that others are exploiting, harming, or deceiving him or her, reluctant to confide in others because they think it's going to be used against them, unforgiving of insults, holds grudges, and then suspects the fidelity or expects their partner is cheating on them, like their intimate partner. So this is our practice. So instead of cases, we're going to be doing this where I ask you to kind of brainstorm what might be, like if you were supposed to make this diagnosis in somebody, what would be a limitation in using these criteria for paranoid personality disorder? Here, I'll click back to it. So what would be something like that, like a person with intellectual and developmental disability would not have access to, like dating, to meet this criteria? So if you're not allowed, if you are not able to date, you might not have this, you might not be able to meet this suspect's fidelity of partner. So like those kinds of things. Okay, so let's see in the chat what you think might get in the way. Communication barriers, absolutely. I agree. Yeah, so the cognitive skills and verbal skills to talk about the fear. So even like getting the person to talk about this. Yeah, and somebody all caps said a caregiver could be abusive. Right, so that history of trauma is very important here. Also, is the person safe? There's that t-shirt that says you're not paranoid if they're really out to get you. And that's true, like it's not a diagnosis if somebody is like actively hurting you or has malevolent intent toward you. So we have to be careful with that. Yeah, so having a payee, you might be suspicious of your payee if they're not like good at communicating where your money is going. So we may not, somebody says they might not have a direct role in managing resources, right? So they might not be able to know if they're being exploited. So it's hard to know if those things are happening. Yeah, so distrustful of others due to not having daily choices, absolutely. And then trust issues due to constant change in support staff. These are all things that I think probably all of us see every day. Yep, excellent. Okay, so that was our trial run for paranoid personality disorder. Thank you so much for participating and for not having me just talk to myself. That would be embarrassing. Okay, so we talked about communication skills. We talked about temper, restrictions on intimacy. Very good. So we talked about those. Oh yeah. So like a coworker with IDD, but higher functioning may really be malevolent. So that idea, like something really could be going on. And I do feel like it's my job to kind of suss out, like, you know, like is this going on? Like, tell me about this. To see if it's really happening. We don't call that a personality disorder. We problem solve, like getting somebody out of that situation. Okay, so our next one is schizoid personality disorder. So this is that social relationship, detachment from social relationships, restricted range and emotional expression. This picture is like a little icy bubble. So that kind of frostiness. They don't desire close relationships, little if any interest in sexual experiences with others, lack close friends lacks close friends other than first-degree relatives, and emotional coldness. Okay, so what would be some of your ideas? What would be the difficulty in using those criteria to make a schizoid personality disorder diagnosis in somebody with IDD? Yeah, so some people with intellectual disability already have a flat expression and don't have a desire to have those relationships. Some might have trouble keeping or nurturing a relationship by not having phone skills or email skills to keep in touch with somebody. So yeah, a lot of communication barriers. Oh yeah, and then trauma history, absolutely. If you hurt me 20 times, I might not be willing to risk being hurt a 21st time. And yeah, somebody makes the very good point that autism can look like emotional coldness, even though we know that's not true. But that kind of like lack of interest or like those social interests. And then somebody says, like never had the opportunity to develop relationships. So having relationships actually takes practice. And that's something, if you're a neurotypical person, that you start practicing like in preschool and elementary school. And a lot of those skills you could just continue to build on and learn and grow. And if you have difficulty taking in and processing new information on like learning, that might be a difficulty for you. Somebody says hyper focus on own interests. Those are very good. Absolutely. Okay, so let's see what the DMID reminds us. Yeah, so are they actually able to have intimate relationships? Do they have access to like a dating pool? Do they, or like especially with COVID, a lot of people just stayed home and are only recently getting back out to like a sheltered workshop or a daytime habilitation program. And then yeah, so DMID2 reminds us that if somebody has autism spectrum disorder, that should be counted as autism spectrum disorder and not this diagnosis. And that yes, we consider trauma. The rates of trauma in people with IDD, it's just too high. It's really, there's a lot of it. And yeah, well, any is too high, but it's especially too high in people who are especially vulnerable. Okay. Our next one, okay, schizotypal personality disorder or schizotypal, whichever. So this is acute discomfort in close relationships, cognitive or perceptual distortions, meaning like unusual experiences like seeing auras, that kind of thing, and then eccentricities of behavior. So just kind of like acting oddly. So ideas of reference. So an idea of reference mean like, oh, this red car just drove past. That means that I should dress in red today. So the idea, or an idea of reference, is the news anchor saying 13 means that because that's my birthday, that that she's kind of mentioning me. So it's like about being referred to when you're not really. So this doesn't rise to the level of like a delusion. It's just this kind of idea that if you ask them, well, is that really true? They can kind of look at it and interpret like, well, maybe it's not true, but the next criteria, hopefully I did okay at describing that. So it's not quite a delusion, but it's kind of getting to an unusual idea. Which is also the next one, odd beliefs or magical thinking. So that's like, the typical answer for magical thinking is like, because I wasn't a good boy, my parents got divorced. So really thinking that it's your fault or you have something to do with something that's not connected to you. So that can also be kind of like working in auras or seeing auras, or kind of the more fringe beliefs can be included there. And then that's true for unusual perceptual experiences. So sometimes people will have like kind of vague, unusual experiences, or they'll see like wallpaper in a different kind of way. And then odd thinking or speech. So people that just talk about things in an unusual way. So like, for example, calling your hysterectomy my Mr. Hyster. So like kind of making up unusual words for things that are just kind of related to you. And then a behavior or appearance that's odd, eccentric, or peculiar. Okay, so we're gonna practice how would having those, like how could you see like roadblocks or bumps in the road and using those to make that diagnosis in somebody who has IDD. Yeah, so people who are neurodiverse often think and act differently. So this one is really tough. I absolutely agree. Who's that? Janet? Oh, hi, Janet. Good to see you again. Right. So like when we are neurodiverse, we do things differently, right? Absolutely. Yeah, that one is very true. Let me see here. And then many of our friends with IDD can be very eccentric and dress the part. Yeah, and I think this is one of those cultural things, right? So like it's culturally appropriate if you collect keychains in the IDD culture to wear your keychains, all of them on your lanyard, which I think is unusual or would be considered peculiar in the neurotypical population, but is like very accepted. Yeah, so clothes could feel different. So if you choose clothes for their texture, that very well could have you dress in a peculiar kind of way. Like if you can't stand wearing jeans because they feel like they suffocate your legs. I think those are really great examples. Somebody else says unique sensory preferences, yes. And then kind of not understanding or not being concerned with social norms. I do think so much of like nonverbal communication or those social norms that are communicated nonverbally. If you don't have those communication skills to take in that information, you wouldn't know that, like, what is it? Oh my gosh, it's totally okay to wear big white tennis shoes now. That's totally in style. So these kind of like style questions, it's just really interesting how nuanced all of the kind of signaling humans have is. And it's really complicated. If you've ever lived with a junior high kid, it's just like goes straight over your head. Like, why do you need Air Force Ones? I don't get it. Those are expensive shoes. So that kind of level of like those kind of nonverbal communications. Very complicated. Okay, so what is the DMID2? Yeah, so magical thinking can also be very common in a person with IDD. Yes, we've talked about unusual styles of dressing, yes, unusual styles of behavior, and then cultural patterns as a whole. Absolutely, so those ideas I would think would make it difficult to make a diagnosis of schizotypal personality disorder in a person with IDD, but you can absolutely, I think you can absolutely make that diagnosis if it fits. And it might be helpful information for the team to have. All right, and the reason you were all here is our next one. Antisocial personality disorder. I bet you're all here for our next one, which is borderline personality disorder, but we're gonna get through antisocial. So antisocial personality disorder is a disregard for the rights of others, criminality, impulsivity, failure to learn from experience, AKA breaking the law, deceitfulness for personal profit or pleasure, impulsivity, aggression, irresponsible. The definition here is like by not holding a job or not having steady employment, lack of remorse, and a history of conduct disorder. So how do you see, like what difficulties do you see using this list of criteria in somebody who has intellectual and developmental disabilities? Yeah, so some of these are coping skills that somebody needs to live. So when yeah, absolutely, I agree. So when somebody is doing a thing to survive, I don't know that I would call that like a symptom of mental illness. That's a survival skill. And very often, I'm actually really proud of my patients who are very resourceful in this area. Like when you have to do something to survive, I do not think it should be counted as a psychiatric symptom. So somebody says, yeah, the rules don't always make sense. Like rules as a neurotypical person don't make sense to me. Like, why am I not allowed to jaywalk? It's actually safer to cross in the middle of the street as opposed to like intersections when it's like two ways. Some of these can be the past effects of trauma. That's a really good example. I like that one. Some of these could be learned behavior. Like if this is your family growing up, like if this is how your family did it, you might just say that's how my family does it. And then, oh, I like this one too. Does the person understand that it's wrong? Like, does somebody understand that the thing that they're doing is against the law? And then somebody, Brian says, some of these can seem like they could be caused by memory impairments. Right, so if you're impulsive or aggressive, and you can't remember, or you're like short-tempered. Agreed. Okay, so yes, I think we covered most of these. Does the person understand that they are breaking the law? And then impulsivity, can the person make a conceptual leap from the present to the future for planning ahead? Also, I just think it's interesting that that marshmallow study has kind of been debunked. That like if you have a person from like an impoverished background, sorry, the marshmallow study is like you'd give kids marshmallows and see how long they can wait until they eat them. You tell them if you save this one marshmallow until I come back, I'll give you 2. And kids from impoverished backgrounds are like, I'm going to go ahead and eat this marshmallow because like, do I trust the grown-up to mean what they say? What if somebody eats my marshmallow first and then I get 0? So there are all kinds of like actual good economic reasons to go ahead and eat the marshmallow once you have it. But yeah, like that kind of idea, can I plan to pass this thing up for right now for future goals? Is a pretty complicated series of decisions. And then does the person have the functional ability to hold a job? There's that kind of responsibility portion of that. And then does the person understand remorse? And then the DMID2 suggests that the individual be at least 21 before you make this diagnosis, and that the conduct disorder diagnosis be before age 18. The DSM-5 TR says age 15. Okay. So please, these are my suggestions. When you're working with somebody who has antisocial personality disorder, please always check for trauma, current trauma, past trauma. It's so important, and it's very often the case. Is somebody on medications that could cause these symptoms? Are they on steroids? Are they on anticonvulsants? If you were here last week, you heard me talk about levetiracetam, which very often can cause like these Keppra rages, is the quotes that are used. And then stimulants sometimes can make people feel really agitated and aggressive. Medical illness, somebody brought that up before. Does somebody have a seizure disorder that is causing this kind of unusual behavior? And then are you seeing are you saying one half of a power play is somebody who's in charge being mean, and then the person is just kind of acting up like as a result of being in this impossible situation? Does somebody have aggravating housemates? We talked about abuse, and then what is the environment that this person is living in? Is it the best environment? Do they have enough freedom? Do they have too much freedom? All of these kinds of things. Oh yes, and somebody says use of illegal drugs, right? So is somebody using methamphetamine or cocaine or like some other drug, or like some of the cannabis strains can cause unusual, I guess, side effects. Okay, and then borderline personality disorder is an instability in interpersonal relationships, self-image, affects, as well as impulsivity. So I listed all 9 here because they're pretty important. So frantic efforts to avoid real or imagined abandonment, intense and chaotic interpersonal relationships, identity disturbance, impulsivity in at least 2 areas, recurrent suicidal behavior, gestures, threats, self-mutilating behavior, affective instability due to a marked reactivity of mood, chronic feelings of emptiness, inappropriate intense anger, and or transient stress-related paranoid ideations or severe dissociative symptoms. So to meet the diagnostic criteria for borderline personality disorder, you have to have 5 of 9. And this is in a person without intellectual disability. Well, I guess this is just like for everybody. You have to meet 5 of 9 criteria. Now, before we talk about this, I want to talk about stigma. And this diagnosis is seriously like the most kind of like hot button pejorative diagnosis that I hear used. And I don't like that. So I'm having us stop for a little bit to talk about stigma. So this isn't a diagnosis to use because you don't like somebody or because you heard they're terrible, or you want to punish them. I use these examples because these are real situations that I have witnessed. I also just see it used as like a mean thing to say about somebody. Like, oh my gosh, you're so borderline, which is like kind of heartbreaking. I'm also, if my bias isn't showing, I'm an outpatient psychiatrist. So I see my patients who have borderline personality disorder usually when they're doing pretty good. Sometimes I'll see somebody on a bad day. So I'm not an inpatient psychiatrist. I have done inpatient psychiatry. So I know that my bias is like that I like working with people who have borderline personality disorder. I just love somebody that can very clearly tell me their symptoms. I think that's wonderful. I also want you to know that borderline personality disorder gets better. I think that's really important to know. And there's some new evidence that shows there have been a couple kind of 10-year-long longitudinal studies that show that people who have borderline personality disorder at 2 years no longer meet diagnostic criteria. And I think that the people I have worked with like very often just get better, and it's been really miraculous. We used to think about borderline personality disorder in a way of like, oh, it's a death, like it's a death sentence. Kind of, well, they're gonna die sad and alone, which isn't true. It's like people working with people with borderline personality disorder has been some of the most enjoyable and rewarding experiences of my career. So I love it. Love it. So if we could just please not be mean to people with borderline personality disorder, and remember that it's usually not personal. Sometimes it feels personal to us when we're the treating clinician, but just to remember as best we can that it's not usually. Okay. Oh, look at this. I already told you all of this. Look at this. Okay. So the literature in people with IDD and borderline personality disorder. As I told you, that was all information in people without IDD. And then there isn't very much. There's some case studies, there's some behavioral interventions, and then I don't know of any medication trials. If you do, please let me know. Oh, okay, so how are we going to adapt these criteria for people who have intellectual and developmental disability? Oh. That's really sweet. Somebody wrote in to say a very sweet thing about stigma. Yeah, absolutely. Okay. Yeah, oh yeah, so staff turnover can feel like abandonment and functionally is abandonment, because very often your favorite staff will like get a new job and they'll leave and you'll never see them again. Sometimes we have direct care professionals who do kind of like keep in contact, but I also understand that life gets in the way of keeping close contacts with people that you worked with before. And so those are like, it feels like abandonment, I think, because it is. Any other ideas about using these diagnostic criteria? Yeah, like the staff turnover is really, really traumatic, because then you finally trust somebody, you like trust them, you like connect with them, and then they leave, and it just feels like starting all over again. Yeah, so somebody says people with IDD have trouble kind of managing emotions, like with the idea of like you have to kind of learn your coping skills. And I don't know, everybody kind of teases me about coping skills, but like, I don't know, I'm like a psychiatrist and I have to consciously use, like, you know, I'm a person, I don't mean that. I mean, like, I'm a person who has significant education. I have a lot of economic privilege, and I'm somebody who has to consciously use my coping skills every day. I'm like, I've got to do my deep breathing. I've got to maintain this. So it takes a lot of practice. So for all of us, yeah, so somebody's talking about like how when a person with IDD, when their favorite person isn't working that day, that like it doesn't mean they're gone forever, that the chronic feelings of emptiness might feel like a loss of a lot of family. People with IDD might be more commonly, they more commonly have self-injury, which is one of the diagnostic criteria here. Let's take a look. Okay, so we talked about how people with IDD are more reliant on caregivers, that identity disturbance can be a really hard thing to understand. It might require fairly sophisticated verbal skills. Self-injury is common in people with IDD. The emptiness, again, is one of those ideas that might need kind of higher level verbal skills to convey, and then the anger problems. Yeah, and then somebody says, many of them know that they are different, and kind of how alienating that might be to feel different. Okay, I don't know. I don't have time to get into my feelings on histrionic personality disorder, but if you read these diagnostic criteria, you will see that a lot of them are just like feminine characteristics. Excessive emotionality and attention seeking has to be the center of attention, inappropriately sexual or provocative behavior, rapidly shifting and shallow expression of emotions, expressionistic speech, self-dramatization, suggestible, and then considers relationships to be closer than they are. So in working with somebody who has, and we can do questions at the end about borderline personality disorder, which is usually the most common area of questions I get. So we can do that then. So for this histrionic personality disorder, so it's kind of like, you know, one of the previous, I think it was DSM-3, was like, talked about like kind of flamboyant gestures while they speak, find hurtful personally. Oh, somebody says, why do you say these are feminine characteristics? So this iteration of the DSM-5-TR has basically taken those out, but if you read the old DSM, like DSM-3 and DSM-3, I think it's R, really read as feminine characteristics. So I'm sorry, yes, thank you for letting me clarify. I do not think these are feminine characteristics. I think all people have these things to different levels. But the older DSM, before they were revised, kind of really read as kind of anti-feminine characteristics, or as like femininity being pathologized. And there's also just not a lot of scientific support for this diagnosis. So somebody says, in response to histrionic personality disorder in people with IDD, so emotionality and attention seeking could be related to not getting enough social attention regularly. So somebody told me that we don't call it, this was a really helpful thing for me. You know how it's like, we call it connection seeking. So people are seeking to make connections. And I thought that was a really helpful reframe. Okay, so a person would have to understand appropriate sexual behavior to then act sexually inappropriately or like provocatively. Communication limitations would be a barrier in making this diagnosis. And then suggestibility, and then that closeness of relation, or thinking relationships are closer than they are. It's not those are just parts of intellectual and developmental disability and shouldn't be considered. So they actually want you to throw out those diagnostic criteria. Yeah, like and somebody says, could those be a result of physical and sexual abuse? Absolutely. So if we have somebody with sexual acting out, we would be worried about PTSD as opposed to histrionic personality disorder. You can have both PTSD and histrionic personality disorder. But like, let's focus on the PTSD and get that treated. Okay, narcissistic personality disorder, grandiosity. Okay, so we are running short. I'm just gonna give you the DMID2 suggestions and leave you to read the DSM-5-TR on your own. Okay, so the suggestions here is that people with IDD may brag about small achievements as a result of experience with repeated failure. And then some of these diagnostic criteria require pretty high level thinking about yourself in relation to others, that kind of like social stratification. And then the empathy note here is that individuals must be able to understand things in perspective and realize that interpersonal relationships require reciprocity. So that empathy might be like that lack of empathy might be like a something that could be worked on or learned. Okay, and then avoidant PD, so this is a very shy person. It's like a, sorry, it's not just a shy person. It's not just social anxiety disorder. It's kind of like a pervasive pattern of social inhibition, feelings of inadequacy. So our notes here is that folks with IDD may have more experience with criticism and failure and may then avoid situations more often. So dependent, oh, sorry. So that was the one note in making this diagnosis in somebody with IDD. So yeah, like you might learn that social situations are painful, which they can very much be. Dependent personality disorder. So the DMID2 just goes ahead and says, like, maybe let's not make this diagnosis. And that the culture of IDD is that you actually, to survive, have to rely on others. So let's not pathologize that. That's like, we're like allowing people to support. Okay, and then this one, this is one of my favorites. So obsessive compulsive personality disorder, it's not OCD. So this is the one that actually people mean when they're like, oh my gosh, I'm so OCD. They actually mean I'm so OCPD usually. So this is a preoccupation with details, needing perfectionism, rigidity and stubbornness, conscientiousness, and pedantry. So this is kind of being very nitpicky. So my thoughts on OCPD. Yeah, so what's the current rate of autism spectrum disorder? And then what does that overlap look like? We have OCD, which sometimes can be like about ordering things, but more often, or like putting things into order, like ordering things. But it can also be like usually like cleanliness, hygiene, 2 hours in the shower, versus autism spectrum disorder, which has that rigidity. And then so does OCPD. So it's such an interesting overlap of these disorders that is a whole talk on its own. I want you to think, when you don't have much control in your life, wouldn't you like your space to look nice? Do you like people touching your stuff? Like just those kinds of reminders that when you don't have like a whole house of your own, when you have like one room and your one good pencil somebody touches and messes up, like those kinds of control issues are, to me, very understandable. I also don't have a whole house. I have to share it with the other people who live there. But, oh, so is the treatment. So is the answer pills? No, I'm so glad you asked. The treatment is not pills. It's bringing the team together to understand the diagnosis. It's the education about symptoms and prognosis, education on how best to approach a person with a personality disorder. Usually a kind, gentle approach works. Very often it's easy to get upset. So it's our job to like keep a hold of ourselves, to practice our good coping skills, to use our deep breathing techniques, to count to 10, and also just to be honest about things, to not be duplicitous, to be upfront as much as we can, a clear discussion of boundaries. Like when you call me 20 times a day, I'm not going to be able to answer the phone 20 times a day. Let's set up a time where you call me at 12:30 every day, and then I can talk to you. And then just working on coping skills. So there are treatments that are modified therapies for people with IDD. So some of the modifications can be shortened session time, kind of more picture, like picture information, kind of more clear instructions, as opposed to like, well, tell me what you think about your mother, or whatever, things like that. Okay, in our 2 minutes, I'm sorry, I really rushed through that, you all. Okay, questions? Okay, yeah, so somebody makes a really great point. People with trauma also seek to control environment and a desire to feel organized and orderly and clean. I think those are really important. Somebody says, what kind of practitioner is best to treat OCD? I would say all of them that you can get a hold of. So I would want a good therapist. I would want a good psychiatrist. I also would want a case manager just for extra support. If we're talking about somebody who has IDD, that also means that we usually have access to the county boards. So we have like the supports and services administrators, those SSAs that are the county board, essentially case managers. Those are really good resources. And then they know also who, if we could get like occupational therapy on board too. Hopefully that was a helpful answer. Oh yeah, I would be glad to send the updated slides. Yep. I'm sorry, I tinker up until the last minute, you all. So, also plug, I'll be back next week to talk about working with, I would say multi-systems patients who have a lot going on. Yeah, and when you're working with somebody who has a personality disorder, taking care of yourself too. It's that idea of like, put your mask on first. Oh, thank you all. That has been very sweet. Thank you so much for coming today.